about that. Good afternoon, wherever you are. This is Madness Scene. It's been a while, guys. It's really been a while. Um, as usual, it's Madness Scene, and we want to have a bit of a conversation. Okay, so this afternoon, we want to talk about hyperkalemia. We want to look at hyperkalemia as you've already seen from this thumbnail, and we will look at some causes, some risk factors, okay, how we can identify them or how best we can diagnose hyperkalemia and how to manage it. All right, so without wasting much time, let's get right into it. Okay. Okay, guys, if you can hear me, this is Madness, and today we are talking about hyperkalemia. I would really love to know where you're watching us from. I would really want to know what your thoughts are. Okay, hello, thank you for joining, and you're the very first person to have joined this live stream today. Okay, I would like to know your name, where you're watching us from, all right, what your, you know, yeah, where you're watching us from, and then we can give you a shout out. Okay, so like you've already seen from the thumbnail, we are talking about hyperkalemia. Okay, so what is hyperkalemia? Hyperkalemia is basically blood levels of potassium that are more than normal. Okay, high levels of potassium in the blood. That is simply hyperkalemia. Hyperkalemia is potassium levels in the blood higher than normal. So at this point, somebody will ask, what is the normal value of potassium in the blood? Hello, thanks for joining and you're welcome. Somebody will ask, what is the normal level of potassium in the blood? Okay, so the normal level is 3.5 to 5. And sometimes some books and labs, send it to 5.5 millimoles per liter. Okay, that is the normal level of potassium in the blood. So anything more than 5 is high, and that qualifies as hyperkalemia. Anything more than 5 is hyperkalemia. Okay, but even that is in stages. So we have the mild form of hyperkalemia, and then we have the severe form of hyperkalemia. Thank you for joining, and let me know if you can hear me. Okay, if you can hear me, say I can or something like that. So the potassium being high also has, classifications. So you can have a mild form of hyperkalemia, and you can also have a severe form of hyperkalemia. A mild one is potassium levels between 5 and 6, or from 5 to 6. Potassium levels of 5 to 6 millimoles per liter is mild hyperkalemia. And then anything above 7 is severe hyperkalemia. All right, let me say that again. The normal levels of potassium in the blood, 3.5 to 5. Okay, so anything above 5 is hyperkalemia. But the hyperkalemia can also be further classified. Okay, so you can have a mild form and then a severe form. A mild form is anything from 5 to 6, and then a severe form is, above 7. Okay, and anything between 6 and 7, maybe you can say that is like a moderate form of hyperkalemia. All right, now let's come back to look at what potassium is. What role does it even play? Do we even need it at all? Okay, so hello Ohiniba, thank you. So potassium is the main intracellular electrolyte. Okay, let me just give you a little bit of a background of intracellular and all that. So in the body we have compartments. Okay, we have the extracellular compartment, we have the intracellular compartment. All right, now the intracellular is the within our cells. You already know that we have cells, right? Cells coming together forms tissues. Is that noted? Tissue comes together, form organs. Organs come together, and then we have a system, right? Now within the cells, we have electrolytes, we have, components. Okay, you have your lysosomes, your ribosomes, you have like mitochondria, your nuclei, and all that. Then we have electrolytes inside the cells. They all have roles to play. Now inside the human cells, potassium is the main electrolyte over there. That also goes to say that there are other electrolytes, but potassium is the main intracellular electrolyte. Okay, I hope you're following me on that. Now, the extracellular compartment also comprises of the intravascular and then the interstitial spaces. The intravascular space is those spaces within your vessels, your red blood cells, your white blood cells, your capillaries, those vessels within them, they form the intravascular cells. Then your interstitial cells, interstitial spaces are those spaces in between your cells. Okay, like in your tissues, in between the cells, those small spaces over there, they're actually filled with fluid. All right, those spaces are the interstitial cells. Sorry, the interstitial spaces. Okay, just have that background for me because I'll have to mention it a bit earlier for us to have a more appreciation. Okay, now let's look at potassium in a whole. So in the human body, 96 to 98% of the potassium content is found in the cells. Okay, we already established that they are mainly found in the cells, but the percentage of them that are found in the cells is about 96 to 98% of the entire, the entire amount. So for example, just an example, if you have like 200 grams of potassium in your system, 96 to 98% of that will be found in your cells. That should be around maybe 180 or something. That will be found in your cells. Then about 2%, just 2% of that will be found in your intravascular. Okay, that will be found in your extracellular, but mainly in your intravascular cells. That is why this definition of potassium is hyperkalemia, emia. Now, anytime you see that ending to any word like emia, that should tell you that it's inside the blood. Okay, if you have hyperkalemia, it means you're talking about potassium inside the blood. Okay, maybe magnesemia, anything you're talking about, calcemia. Anytime you hear the word emia, it means inside the blood. So about 2% of the entire total body, amount of potassium is found inside the blood, and it shouldn't be more than that. So anytime you get it going higher, then it becomes a problem, and that is where the potassium comes from. So that 2% of whatever the amount is should sum up to about 3.5 to 5 grams per 5 gram millimoles per liter. Okay, because we are all not equal, we can't all have the same amount, so it's a range. All right, 3.5, yes, is normal for somebody, 5 is normal for somebody. So the range is from 3.5 to 5. That is what you should have, okay, in your blood. All right, so now that we have established that, let's look at what role potassium plays. Now, it is mainly found in your cells because it's supposed to enhance cellular activity. It's supposed to give the cells that, strength. It's mainly found in your muscles. Okay, it is mainly found in your muscles, and you know that our muscles are what supports our skeletal system. Our muscles are what gives us, that energy, that thing to work. All right, we use muscles a lot. There are lots of them. Okay, you have your pectoralis, major pectoralis, minor. That is in breathing. You have your abdominis. You have women. We have a lot of muscles in our pelvic floor, and we all know the wonderful works that they do over there. So potassium actually helps your muscles to function and function very well. That is why they are mainly supposed to be there. Okay, whereas they are supposed to be found somewhere, they are not supposed to even flush some part of your system. Okay, and we'll be going deeper into that as we go. So let's look at the causes. Okay, let's look at what can cause hyperkalemia, because mind you, we are actually talking about hyperkalemia today. We're mainly talking about hyperkalemia. So what are some of the causes of hyperkalemia? What can cause hyperkalemia? One example or situation that can lead to hyperkalemia is renal dysfunction. Okay, your renal function going down, your glomerular filtration going down. That can cause a lot of problem. Now, potassium is supposed to be excreted. Okay, let me give you a little bit of what the normal, human being on normal circumstances, everyday life is supposed to be like. Now, the 3.5 to 5, that is the normal potassium that you're supposed to have in your system. You can actually have more than that just by eating a meal. I don't think there's anybody here who doesn't take potatoes or tomatoes or plantain. I don't think there's anybody there like that. So majority, almost everything we eat in a day has potassium. Okay, so the body is defined in such a way that immediately you ingest in excess, there is this mechanism called the ATP pump. Okay, the adenotriphosphate pump that takes the excess from the blood into your cells. Okay, so anytime you eat and you have excess potassium in your system, it is taken into the cells by the ATP pump or the adenotriphosphate pump. Okay, now Your glomerular function, if it's correct, if it's working 100%, your kidneys are good, the excess will also be excreted in your urine. Okay, so have this in mind, that no urine, no potassium. Okay, it's supposed to be excreted, and then it's supposed to be transferred into your cells. So if that doesn't happen, then there's going to be a problem. So one of the main issues that can lead to hyperkalemia is poor renal function. Your kidney is not functioning well. Your glomerular filtration is poor. Let's say it's less than 30, or it's about 30 or less. Potassium cannot be excreted, and so that can give you hyperkalemia. So patients with kidney failure are at very, very high risk. In fact, they are most of the times already having potassium levels high. Okay, somebody with a CKD, a chronic kidney disease, or somebody with a diabetic nephropathy, somebody with a hive and like an HIV associated nephropathy, or somebody with a hypertensive nephropathy, okay, most likely has hyperkalemia. All right, so we need to be very, very careful when we are dealing with people like that. Monitoring their potassium levels, managing it properly, making sure that it doesn't become that lethal dose is very, very important. Okay. Another way that you can have hyperkalemia is through what we call an AKI. You know, there's a difference between an AKI and somebody who has a kidney disease. An AKI is an acute kidney injury. That will definitely affect your filtration rate, will definitely affect your urine production anyway. But this AKI is of a different level. AKI can be caused by anything. It can be hypovolemic. Okay, maybe kidneys are not really being perfused for some reason. There's hypovolemia, and so kidneys are not getting, enough. Maybe there was a shock of any kind. It could be septic, it could be, hypovolemic, it could be anything, and the kidneys are not being perfused. That instant moment, you are at a very high risk of your potassium going high, and so you need to pay very, very attention and monitor closely. Okay, it can also be, an intrarenal cause. Maybe there is a tumor, maybe there is an inflammation, okay, inside your kidneys, and nephritis, whatever kind it is. You are at risk of hyperkalemia. Okay, another cause of hyperkalemia is trauma and crash injuries. Like we said, they are mainly found in the cells. Okay, they are mainly found in the cells. So if they are mainly found in the cells, then if there is any breakdown, if there is any trauma, if there is any crash injury, if there is anything that has led to the breakdown of the cells, then potassium can be released into the bloodstream. All right. Okay, so we've been talking about hyperkalemia so far, right? We've spoken about, what hyperkalemia is. We said that it is high levels of potassium basically in the system. Okay, we spoke about potassium being the main intracellular. We said also that about 98% of potassium in the entire body is found in the cells, and just about 2% is inside the blood. Okay, and then now we're talking about some, circumstances that can lead to hyperkalemia. We've spoken about excretion, poor excretion. Okay, we've spoken about kidney injuries, we've spoken about crash injuries. And another instance that I can give you is acidosis. Okay, when there is acidosis, when the pH is down, all right, what happens is that the hydrogen ions, okay, will now shift into the cells, and then potassium will come out of the cells. So anytime you have an acidosis of a salt, if you have a DKA, you have a lactic acidosis, whatever acidosis you're having, your patient is most likely to go into hyperkalemia, because the hydrogen ions will move inside the cells and bring the potassium ions outside of the cells. Alright, so acidosis can also give you hyperkalemia. Okay, now there is one thing that I want us to pay close attention to. Blood transfusion, okay, blood transfusion can end your patient into hyperkalemia, especially if your patient is severely anemic. Okay, hello, Yao from Pong. Thanks for joining. You're welcome. If your patient is highly anemic and you need to give about 3, 4, 5 units of blood, your patient is at risk. Maybe if your patient is already having some little risk of, having a high potassium already, before you give your before you give your blood, then it's even worse. Do you know why? Your red blood cells break down. So if you have a blood that is old in the blood bank, not a fresh one, our red blood cells within 120 days they break down. Is that not so? So they keep breaking down, and they release that potassium content out of them into the interstitial spaces. So the plasma will not be full of potassium, okay, because it has been broken down. That is why it is advisable that you want to transfuse blood for patients that you probably suspect that they might be having some hyperkalemia or can go into hyperkalemia. Then you need to transfuse them with fresh blood. And with fresh blood here, I mean blood that is just, donated. Okay, just call the donor or a relative, and then you quickly take the blood and then you transfuse the patient. Not blood that has already been stored inside the blood bank, because that might have already have some potassium inside because the red blood cells are broken down. I hope you really get what I'm trying to put across here. Okay, so blood transfusion can also give you hyperkalemia, and so we need to pay very close attention to that. Now, there is a reason, okay, why we don't want potassium to go high. And you see, because most at times it is silent. Most at times it doesn't have symptoms. Okay, if you want to talk about symptoms of hyperkalemia, maybe nausea, vomiting, some muscle tremors, okay, some neuropathy, some abdominal pain, maybe, things that are symptoms of almost like, there are lots of conditions that can give you that symptoms. Headache, nausea, vomiting. You can get that from any disease. And so if you are not that caregiver, you're not that nurse, you're not that medical practitioner that is proactive, you're not that person that can think outside the eyes of the box, okay, you don't think ahead, you might miss it. Okay, then you can have palpitations. Now, by the time you get to palpitations, then it means that it's becoming more cardiac, and that is the problem. Potassium is not good for the heart. Potassium is an instant killer of the heart. It will shut the heart down in seconds. That is how alarming that electrolyte can be if it's high. Now, mind you, if we have hyperkalemia, then we have hypokalemia as well. Okay, but the hyper is more dangerous than the hyper. So how do you know it's affecting the heart? Now, if you're not able, if you don't have the suspicion to take blood levels of the potassium, then you can rely on your ECG. Okay, and here on Smart Nursing we have a detailed, teaching on ECG. We actually went through the basic ECG, the normal rhythm. Okay, the normal rhythm, what we call the sinus rhythm, the normal one, how it's supposed to be. Now that is the baseline. If you know that, then any other thing is a problem. Okay, so when you look at the T wave, this is what determines what is going on with hyperkalemia. Okay, so on that note, we are zooming into the ECG changes of hyperkalemia. Now, by the time you start seeing ECG changes, your potassium level is most probably 7 or more. And remember, we said that 7 is severe and is lethal, is deadly. Okay, potassium level of 7 is a problem. All right, now if you wait, or if you're seeing ECG changes by chance, then you're looking at a potassium level of 7. Now, what are those ECG changes? The T wave being tall and tinted. Okay, if we say it is tall, it is something that is very tall like this. Okay, and it goes up and comes down like a tent. Okay, when you look at the T wave of an ECG, that, a hyperkalemia ECG, okay, you will see the T wave that it is tall and it's tinted like this. That tells you that your potassium is already at 7 and you need to act very fast. All right, now if nothing is done, the wave will begin to widen. Now, widen in wide, it will be wide. It will now be getting bigger, 3 small boxes, 4, 5. Okay, it is increasing. And if that is increasing, your T wave is also widening. Now, as that progresses, it will keep widening and widening. Okay, and then it will form this wave that we call the sine wave. You know that sine symbol, right? The sine symbol in physics. Okay, something that goes up and comes down like this. All right, your reading will begin to look like that. And if it progresses, it will keep going and then it will become flat. Then you will see a flat line, what we term as the asystole, and that is a cardiac arrest. Okay, and this can happen within, minutes. All right, so first you're going to see a tall and tinted T wave, then you're going to have a widening QRS, you're going to have a sine wave, then you're going to have a flat line. That is the progression of, the ECG changes of hyperkalemia. Okay, if you begin to see that tall and tinted, then you need to act very, very fast. Okay, and the first thing that you will do with hyperkalemia management is to stabilize the cardiac myocytes. You want to stabilize your heart. That is your priority, your topmost priority. Okay, in managing hyperkalemia, your topmost priority is to stabilize your heart. And if that is the only thing that you're able to do, it's still worth it. Okay, at the moment, because there are a number of things that you have to do to take the potassium out. Now, if you've stabilized the heart, it's like forming a fire belt. Okay, maybe there is a bushfire and you have a vegetable farm, a nice one. You don't want the fire near the farm, so you have a farm belt. Okay, you clear some areas, around the farm to create a belt so that the fire cannot get to your vegetables, but you have not stopped the fire entirely. Okay, so even if you stabilize the heart, you still need to do other things, the potassium out of the system. But the most important thing, the first thing to do is to stabilize the heart. Because again, if you want to liken it to the farm and the bushfire, if you want to go and stop the fire or quench the fire, by the time you come back, your garden might have been burnt down. So creating that farm belt is the priority, is the main thing to do. Okay, so the first thing we do in hyperkalemia is to stabilize the cardiac myocyte. Okay, and by stabilizing the cardiac myocyte, what do? You need to give a drug called calcium gluconate. You need to give a drug called calcium gluconate. Now there is an entire, you know, there's a whole procedure, there's a whole thing. I mean that there's a whole ball game on its own when we want to talk about management of hyperkalemia. Okay, so I think that we will have to do that in another video so as not to, you know, make it too bulky. Okay, so you can actually come along with me, understand what I am talking about. So I will leave the management to another time. Okay, but I just want you to get that concept that when you want to manage it, you first need to stabilize your heart. All right, because you know that if your heart stops, then Charlie, you're not going to be doing cardiopulmonary resuscitation, and nobody wants to get there. Nobody wants to get there. Okay, so that is that. So what have we been talking about so far? We've been talking about hyperkalemia, we've been talking about potassium, we spoke about its normal, you know, values, and we said that it is 3.5 to 5 millimoles per liter. I mean, the unit will depend on the labs, okay, and usually every lab has its own ranges. Okay, basically it's within 3.5 to 5. Okay, so anything less than 3.5 is low, and that will be hypokalemia. Anything higher than 5 will be hyperkalemia. Okay, and again, I must say that the levels we are talking about here, or the values we are talking about here, are what is found inside the blood. What is found inside the blood, because like we said or established earlier, the main intracellular electrolyte is potassium. Okay, aside that, about 98% of the total body, you know, amount of potassium is found inside the cells. It's supposed to be in the cells for optimum cellular activity, right? For the cells to function as they're supposed to be, they need potassium, and they need about 98% of the total in the system. And I gave an example that if you have about 200, then you need about 98% of that 200 to be inside your cells. Okay, and then the rest 2% should be inside the blood. And now on normal circumstances, when you eat, because I mean the main form of ingestion or how we get potassium basically is from food. Okay, unless maybe there's some supplements, somebody is taking a KCL, or somebody is taking, you know, oral supplements, low K and all that, that can also give you some you know, increase your potassium, but mainly it is from food. Now what happens is, because we don't need too much of it in the bloodstream, immediately you eat, the ATP pumps, you know, takes it and shift the excess into the cells. Then the rest is actually excreted. So you need a good renal function, and then you need your ATP pump, your adenotriphosphate pump, to be up and doing to keep you going. And basically that is a summary of what happens in a normal human being system that is not diseased or impaired in any way. Okay, so what that means is that if by any chance you are not fine. If there's any problem with your pump shifting the potassium, or there's a problem with your excretion, then you can have, problem with potassium basically. Okay, I hope you're getting me. And I really want to appreciate my um audience here, I should say, for sticking and staying. All right. Thank you so much. It means a lot to me, and I would really wish to hear from you. All right. Know your name and where you're watching me from. If you're picking a thing or two, kindly let me know, because it will really mean a lot and push me. All right. So let me know if you can hear me, and let me know where you're watching me from. All right. So, like I was saying, those are the mechanisms put in place by nature to regulate, potassium. Okay. So, the risk factors of having hyperkalemia are: one, poor renal function. Okay, because we said that excretion is key, it has to be excreted. Okay, sodium sometimes, it depends. Okay, it depends on the situation. Your renal angiotensin, you know, aldosterone angiotensin system, your RAS system. Okay, if it's functioning properly, your glomerular filtration is up, all your kidneys are good, potassium is supposed to be excreted. All right. So if kidney function is bad, then potassium is being retained, then there's a problem. That is why every renal patient, any patient with a kidney problem, okay, it's already at risk. All right. Any patient with a kidney problem is already at risk, or probably has a hyperkalemia already. So you need to be very careful. Now, anything that can affect your kidney is a culprit. So if you're a diabetic patient, your kidneys are, sorry about that. You're a diabetic patient, your kidneys can become compromised. So you need to regularly check your kidney function. Sorry. Okay. And if you're diabetic, even worse. All right. We also have, tumors. We have AKIs. We have some medicated associated nephritis. Okay, some NSAIDs. You know what NSAIDs are, right? Those non-steroidal anti-inflammatory drugs like diclofenac, like brufen, like colchicine. Okay, they can actually cause inflammation inside your kidneys. So anybody that is on those drugs, you need to be paying close attention to your potassium, because it can cause reduced renal function, which will lead to retain potassium, because potassium is not being excreted. So anybody that has less urine production, okay, has an estimated glomerular filtration rate of about 30 mils per hour or even less, okay, that is a big deal. All right, so what I want you to take home is that no urine, no potassium. If you're not producing enough, it means you're not excreting enough. Okay, then we also said that crash injuries or trauma, anything that crashes your skin or your muscles. Okay, maybe you had some mangled limb from an RTA, building collapsing on you, any trauma, anything, burns, okay, burns that destroy significant, total body surface. If you have a burn of 50% or more, you should be worried for your potassium in your kidney. Okay, and then I also made a very important you know I pointed something out very importantly about blood transfusion. Okay, and I said that if you are worried or you are concerned about your patient's potassium going up, maybe the person already has a risk of hyperkalemia, then if there is the need to transfuse blood, it should be a fresh blood and not an old one. Okay, always endeavor to give fresh blood to your patients that you are concerned about their potassium levels. If you're concerned that they may have hyperkalemia, then please give fresh blood. Don't give a stored blood. And the reason simply is because your red blood cells might have already been broken from that blood that has been stored for a while. You know, by 120 days, they are broken down. Your red blood cells go after 120 days, right? So if it's not fresh, you must be concerned. Okay, so we went ahead to talk about ECG changes. Okay, there's some ECG changes that you see in hyperkalemia, and I said the first one is a tall and a tainted T wave, all right, which will progress to a widened QRS, which will progress to a sine wave and then a flat line and asystole if nothing is done. All right, and then why thumbnail is what it is because potassium is no good for, it's very lethal for the heart. Whilst it's very needed in the muscles, it is not good for the heart. Okay, so a potassium level of 7 can shut your heart. It can completely put your heart off guard. So the first thing you need to do in hyperkalemia is to stabilize your heart or stabilize your cardiac myocytes by giving what we call calcium gluconate. Okay, so I want us to defer the management to another day. Okay, let's talk about the management of hyperkalemia another time, all right, where we go deeper and deeper into how we manage it in emergency situations and maybe even long-term management. Okay, because I will need you to really understand what we do. All right, so at this point, if you have any questions for me, I will take them and I will try my best. I'll try my possible best to answer them. Okay, if you have any questions for me, I welcome them now. So Ohiniba Sebe Yeboah was here. Yosen from home. All right. So it's time for questions. It's time for questions, and let's see what we can do to answer them. Okay, so one NCLEX tip that I will give you, one NCLEX tip that I will give you is that, no urine, no potassium. If your patient is not producing urine, my sister, know that the potassium is probably even high. Okay, so you can administer potassium in that regard. So any patient with renal dysfunction is a candidate. It's a candidate for hyperkalemia. Okay, and the first thing, your priority, your topmost priority, your topmost priority in managing hyperkalemia is giving your calcium gluconate, okay? It's giving your calcium gluconate. Yeah, your calcium gluconate is your priority in hyperkalemia because that is what stabilizes the heart. Why? Because you don't want the heart to stop. Okay, and you see, one other danger about hyperkalemia is that most of the times your vitals may be normal, so you might just find them by chance, and that is why it's very, very important to keep monitoring your patients. Anybody that you suspect may be a candidate of hyperkalemia, it's very important to keep monitoring them closely because your vitals can be fine and they will take you by surprise. Okay, so if you're just joining us, we are talking today, all right? And I would really want to know where you're watching me from. My name is Evelyn and I'm Ines. Okay, I've been practicing for over a decade now and I live in Ghana. So I want to know where you're watching me from. If you can hear me, I'd like to know your name and where you're watching me from. And if you have any questions for me, okay, questions on what we're discussing today. Hyperkalemia is high levels of potassium in the blood. Okay, and just by way of emphasis, I said earlier that the normal level is 3.5 to 5. Okay, the normal level is 3.5 to 5. So that means that anything higher than 5 is hyperkalemia. You know, anytime you hear hyper, you know that it is high. I mean, more than normal, and hypo is not less than normal, right? So anything higher than 5 millimoles per liter, that is hyperkalemia. But even that can be broken down again into, is it 2 or 3? Okay, so if you have a level of 5 to 6, that is mild. And if you have between 6 and 7, that is moderate. Now anything higher than 7 or above is severe. Okay, and that is a problem. Usually you don't really have symptoms. Okay, if you're having a symptom, you may be confusing away other things. That is why if you have any candidates, then you need to be, very, very observant and very careful in monitoring them. Okay, all right. Any questions? Any questions for me? All right, so I will just give you another tip here. Now, Ringer's lactate, we look at the components of Ringer's lactate. It has some amount of, potassium in there. All right, so if you want to administer Ringer's lactate, you need to be careful with your patient's kidney function. Okay, you need to be careful with your patient's kidney function before you give your Ringer's lactate or lactated Ringer's. I'm ready for questions, guys. Okay, so I will go a little bit into the management, okay, of hyperkalemia, emergency management of hyperkalemia, but then we will just give it a little bit of a touch so that we continue another time where we go deeper. Okay, and then I will tell you why we give those drugs and how they help in management of hyperkalemia. Okay, So when you look at it, we give something that will stabilize the heart. Okay, that is the calcium gluconate, right? Then we give something that will clear the potassium out of the blood. Now, in clearing the potassium out of the blood, there are several ways. Some of the ways are taking the potassium out of the blood into the cells. Remember, that is what is supposed to be normal anyway. That is what is supposed to be done anyway. So in the management, you're going to give a drug that will take the excess from the blood into the cells. You're going to approach it in another way by also giving a drug that will make it to be expelled by air, like aerosol it will be. So you breathe out the excess, breathed out. I just the English is coming, it will come out through your breath. Okay, as you breathe out, you bring it out. Then another way is to pass it through the GI. All right, so you give drugs that will take your potassium out of the blood, but your topmost priority your topmost priority is to stabilize your heart. Okay, because potassium is very little for the heart. It will give you arrhythmias. It will make you very, very unstable. Trust me, you don't want to see any patient with an arrhythmia. It's very, very discomforting for the patient. The patients are restless. Sometimes they are confused. Sometimes they are, they are not breathing well, difficulty in breathing, unconscious. It's very frustrating. It's very frustrating. And we have a lot of arrhythmias, right? You have the narrow complex, you have the Y complex, okay, your atrial fibrillations, your ventricular tachycardias, your SVTs. It's very frustrating. It's very frustrating if your patients are in dysrhythmias, and that is what hyperkalemia can cause. Now, if nothing is done about it, or they decide not to respond to your medications, then your patient is going to arrest. Potassium is very lethal. It kills just like that. That is why we need to be very careful. Now, if your patient arrests, you now have to start your CPR, your protocols, your ACLS. And if you live in the part of the world that I do now, you realize that most of the facilities are not very resourced, okay. Alright, not every facility has the resource to manage this kind of situations, like a cardiac arrest. To run a full code is not a luxury, okay, in most parts of the world, in most of the hospitals. So you want to avoid getting there. You understand what I mean? You want to avoid getting there. You don't want your patient to arrest because you don't have the resources. You don't have the ability, you don't have the capabilities to run a full code. Okay, and hyperkalemia can take you there. So if you can prevent it from happening, why not? If you can prevent it from happening, why not? There is something in management of diabetes. It can be very dicey, especially in the emergencies. if you're having an HHS and you're having a DKA, okay, you need to be very careful. Alright. I said earlier that acidosis can cause hyperkalemia, and the way it does that is that it makes your hydrogen ions to go into the cells, and then potassium comes out into the bloodstream. An example of that situation is in a DKA, alright, in a lactic acidosis, sometimes in sepsis. So if your patient comes in with very high sugars, maybe a non-diabetic or not a non-diabetic, or even a child, juvenile hypertension in most parts, in our parts of the world, usually they present with DKAs. So even a child can come with sugars flying around in the roof. You need to take your ketones. You need to test for ketones. Okay, if your blood ketones will take time, you quickly need to do a urine dipstick to ascertain whether there are ketones in that blood or urine or not. Okay, if you have ketones in your urine, then please be very careful. Have it at the back of your mind that this patient's potassium may be high, and you quickly take blood samples to run your electrolyte. I am saying this because we often think, or we tend to generalize management of conditions without being patient specific or presentation specific. We tend to give KCL blindly in managing, high blood sugars. We tend to give KCL, potassium, blindly in managing high blood sugars. It's just because we assume that the non-availability of insulin that is causing these patients sugar to go high needs to be corrected. And so we go in with our insulin. Therefore, insulin will cause a potassium shift. Please pay attention to it. Well, that is true. That is true. That is even why one of the risk factors of hyperkalemia is a patient whose diabetes is not being controlled. Okay? If you don't have insulin in your system, your diabetes is not controlled. So that ATP pump will not work. There is no way potassium can be shifted into your cells because you don't have insulin. Because one of the functions of insulin is to shift potassium into your cells. Okay, that is why when we talk about the management of hyperkalemia, you will see that even insulin is given to shift the potassium into the cells. So most of the times it is assumed that anybody that has high blood sugars and is being given insulin will need to have potassium replaced. Okay? That is the assumption that anybody that has a high blood sugar, okay, maybe the patient came to the emergency, you check the blood and it's like 30, 33. Sometimes it will give you HI, which means that it is even higher than it's programmed to read. The highest level the machine is programmed to read is HI is high. And then you want to give insulin, and because you don't want to further reduce reduce the potassium, you want to replace it. Let's be careful. Let us establish whether there's a diabetic ketoacidosis ongoing or not, or it is just an HHS or an HNHS, whichever way you want to call it. It is just a hyperglycemic hyperosmolar state, or it is a hyperglycemic non-ketotic, whatever it is. Okay, let us be sure. Let us establish whether or not there are ketones present before we go ahead and give our insulin plus our KCL. Because if there are ketones, it means that already your potassium may be compromised on the high side. So giving an KCL is just worsening the situation. It is worsening the situation. Okay, if it is not a DKA, you are safe. But what if it's a DKA? So it's very important to, check our ketone levels in situations of, high blood sugars or management of high blood sugars before we cause further destruction. All right, that is why it is highly recommended that before you get your electrolyte levels or your ketone levels, start with normal saline. Run your normal saline and be safe to bring down the sugar until your electrolytes arrive or until your ketones arrive. All right, so thank you guys very much. My name is Miss Evelyn. Like I said, we've been talking for the past 1 hour or so, and we've been discussing hyperkalaemia. Okay, and we said that it is a silent killer of the heart. If it's high, it's not good for the heart. Okay, silent because it might not give you signs and it will just shut you down all of a sudden. So if you have any chronic disease that can affect your kidneys, be careful with potassium. Okay, if you're patient or caregiver, a student, even better, you need to monitor your cases very, very closely. And remember, no urine, no potassium. Okay, no urine, no potassium. And if your kidney function is poor, then you're at risk of hyperkalemia. And also remember or note that the first thing to do in management of hyperkalemia is stabilizing your heart muscles. This has been Smart Nursing. Thank you very much for joining. Thank you very much for listening. We will see you in another video. Okay, bye-bye. Oh, hey, thank you for coming. We're just about signing out. Can you say hi? Let me give you a shout out before I go. Okay, see you guys in another video. Right? Love you. Bye-bye.